Hey, everybody, and welcome to day 3 of the 12 days of articles in review for 2021-2022. My name is Mary Coughlin. I'm a neonatal nurse practitioner by training, and I'm the president and founder of Caring Essentials Collaborative. So today's paper is titled "The Trauma," with quotes, in Trauma-Informed Care, written by Sophie Isabelle. Sophie is out of Australia and is a psychiatrist or in the mental health professions. And I came across this paper and thought it was really interesting, even though it's not related to prematurity, but it kind of speaks to that broader challenge, broader context of this idea of trauma and trauma-informed care. I've placed the title of the paper and the DOI number here in the chat box. So if you're interested in grabbing that, just go ahead and copy and paste or whatever it is that you do to access the paper. I was fortunate enough that the author shared the paper with me. So, okay, so I thought it was interesting to kind of present this paper during this series because it was through my experience with working in a mental health capacity that introduced me to this concept of trauma-informed care back in, I think it was Willikers 2013. Was it 2013? I apologize. 2012, the end of 2012, where I was working in a community hospital, like not too far from where I live, and as a director of professional practice in education and research. And we have within the hospital an inpatient adolescent psychiatric unit. There's also an adult and an older adult inpatient psychiatric units. And I was called into my boss's office and asked to step in as the interim nurse manager on the adolescent psychiatric unit. I don't have any psych nursing experience. Nursing school certainly didn't count, but they felt that my background as a NICU nurse gave me pediatric skills. So, okay. So I stepped into the position and I was there for 4 months in that capacity and got to work with some really amazing clinicians. I had 2 colleagues that were clinical nurse specialists in psychiatry, and they really helped me get a handle on the environment, get a handle on the concepts, and introduced me to this idea of trauma-informed care. And so when I came across this paper, I found it really interesting because as I had read previous to this, the concept of trauma-informed care has about a 40-year history, probably 50-year history now, in mental health and in behavioral health. But this paper really just highlighted the ongoing challenges and struggles with the concept within the world of psychiatry. And so I thought that I would share this with you because I saw some parallels with what the author was presenting and some of the challenges that we have within medicine, outside of behavioral health, adopting and aligning with this concept and seeing the relevance and trying to also strategize about how to integrate such a somewhat nebulous concept or paradigm within a very reductionist oriented environment. So Sophie opens up and just shares that her objective was really to get a better handle on what were some of the challenges in embracing trauma-informed care within mental health services. And she, in her paper, she recognizes the challenges really kind of revolve around how people currently view trauma-informed care, and really view their role within the service line that they're providing care, the service line that they're providing. So specifically psychiatrists. So she talks about, that the concept is viewed within mental health as really challenging because there's lots of different definitions of trauma. So, and I've kind of used my understanding of the definition of trauma from the Substance Abuse Mental Health Services Administration here in the United States, right? That trauma is the 3 E's, right? It's an event that's experienced by the individual and has lasting effects. And the event is perceived as either life-threatening, physically or emotionally, that overwhelms the individual's ability to cope. And so, and the earlier that you're exposed to trauma, the more pervasive the consequences or the effects of the trauma experience. So I thought, well, okay, I get that, and I can figure out how that works. And so I was intrigued by the challenge that the author presents in this paper about the acceptance of trauma within mental health services. And I'm just kind of scrolling down to highlight how the perceptions have been verbalized as it, you know, that the concern is that anybody can say that they're a trauma survivor. That they felt that the lack of discrete definition and discrete criteria kind of, left it open, like it was a free for all, like anybody could say, I'm a trauma survivor, and that somehow was off-putting, and that some of the psychiatrists felt that the perception, the presence of trauma complicates real psychiatric practice, and felt kind of like, what was the word that she used? They were definitely off-put and resistant to the idea, and that people within this, as captured in this paper, that mental health professionals felt that they would then kind of use this term that I'm unfamiliar with, but othering. So that trauma-informed care kind of put people in this separate category when they expressed that they were trauma survivors. And although the clinicians felt that was a good thing, that it kind of like was being benevolent in its intentions, it really, again, just continued this marginalization or ostracization of these individuals that had survived trauma and then were presenting with mental health challenges. So it felt really eye-opening, and helped me get a better sense of possibly some of the challenges that exist within neonatology and pediatrics as we talk about trauma and trauma-informed care. The author in this paper talks about how many of the care practices within mental health can also be traumatizing. And I could relate to that, because I thought, well, many of the care practices that we provide in neonatology, for sure, absolutely can be traumatizing, and that really creates a level of like distress to the clinicians, and I've had actually clinicians say this to me, like, are you trying to tell me that I'm causing trauma to my patients, that I'm traumatizing the patients? And I think, what this discussion opens up for us is the opportunity to really kind of explore our feelings and our relationship with our work, and what is the intention of our work, right? The intention of our work is to heal, right? Is to help people recover from whatever their condition is, whether it's a physical illness, whether it's a mental illness. We're trying to help people heal from that, and in the journey of that recovery, or that transition from illness to health. If you look at health and illness on a continuum, there are some interventions that can be distressing. And so I think if we don't recognize the nature of these interventions can be distressing, and that there's an opportunity for us to mitigate and manage that distress while still delivering that intervention, then we're kind of missing the point of what it is to be a healer. And I find also that we have folks struggle with the use of that word too, right? That people say, I'm not a healer, I'm a therapist, I'm a nurse, I'm a doctor, and some of these disciplines align more comfortably with that label or that term of being a healer, and some folks don't. And actually, as I say the word label, that was another thing that was brought up by the author in this paper, that people get assigned this label of a trauma survivor, and then that somehow then gets them certain things, right? That there's some benefits of identifying yourself as a trauma survivor. So it was a really interesting take on the language, right? On the language of trauma and the language of trauma-informed care. she also points out that, that diagnostic systems can compound the confusion. That's one of the sentences that she uses here in her paper. And that also helped me kind of gain a little bit of understanding about how this paradigm can be challenged or be challenging in neonatology, right, or in pediatrics. We're a very diagnostically driven system. So how does the trauma piece of it fit in? And it may not be as overt in the world of pediatrics as it is in the world of mental health, but I think it's worth discussing. That I know there's, when we look at the American Academy of Pediatrics papers, and I'm going to be presenting them in the next few days, and they talk about screening folks for trauma history, right? Within pediatrics, how do we screen families for trauma history? And there's debate about that, and I think the debate, although this paper, this author doesn't talk about that challenge overtly, she does kind of hint about, the screening process, that intake process can actually be re-traumatizing to the individual. And is it really necessary to diagnose a trauma history necessarily? But just understand that the majority of people do have a trauma history, and that then informs how you show up, how you engage, how you connect with the individual. The author talks here in her summary section of the paper about how the discourse of trauma is decidedly political, and that accepting broad definitions and the uncertainty of etiology of trauma within psychiatry requires alterations to power structures and medical jargon, and that can be off-putting and distressing to those that are well established in their practice. But when we do that, we're really giving voice to those that are disempowered. And that's the patient, right? And certainly patients in mental health services can feel very disempowered by the nature of the system and how the system is set up. And I've bore witness to that, and I can see how disempowering it is, and possibly even marginally dehumanizing. And I see similar phenomenon within the medical world, where patients are disempowered and can also be marginally dehumanized in how we connect with them. So this language, we need to continue to talk about it. We need to continue to explore what it means, to have a trauma experience. What is it? What is trauma? Is it? And my understanding, is it's a highly individualized phenomenon. There are core connected experiences that thread through humanity, right? Feelings of a loss of safety and security. And that could be experienced through a variety of different detailed lived experiences of trauma, but that the core experience conveyed to the individual a lost sense of safety, security, and connectedness, which is disempowering, which is isolating, and all that kind of stuff. So we have to continue to have these conversations. And we also have to be reminded, and I like how the author includes this in her summary, about she says, to be truly trauma informed requires consideration of the social and political context in which trauma occurs, and the recognition of social and health policy inequities that sustain its effects. And that's, looking at the trauma that is systemic in our healthcare, in our social situations, poverty, racial inequity, gender inequity, all of this kind of stuff that creates a backdrop that allows for these trauma experiences to happen, whether these trauma experiences are full-on overt abuse, bullying, poverty, all of these different types of things. We need to really understand that. So when we talk about being trauma informed, kind of like on the first pass, I'm thinking of that interface of care and how I can be trauma informed and connect with the human needs of this individual who is now frightened, possibly alone, in pain, confused, all of these kinds of things, and whatever history they've had that informs this current experience, right? I need to be sensitive to that, but I also need to be aware of the larger picture and advocate for those changes that can help mitigate and reduce the circumstances that create opportunities for trauma to actually persist. So I think, you know, I found it a really interesting paper, and I found it interesting that what I thought of within behavioral health and this construct as being well established, and they're probably like, you know, the people that we need to turn to. And I'm not saying we shouldn't turn to our behavioral health colleagues and partner with them in integrating and adopting this mindset, if you will, this paradigm into healthcare, but that they also struggle with this. And I think that there's a sense of security in that, and recognizing that we need to keep the doors open, right? Keep our hearts and minds open and continue to have these conversations, have these discourses about this language that is new, that can be jarring, that can make us feel uncomfortable. Because when we lean into that discomfort, that's when we discover new ways of transcending the lived experience of trauma, the lived experience of suffering and isolation and all that kind of stuff. So what she talks about here in her conclusion is that trauma-informed care is reliant upon a concept that has assumed meaning and evokes conflicting responses. There are opportunities for clinicians to reflect on what trauma means for the people they provide care to, and is critical for progressing any attempt to deliver care in ways that are sensitive to trauma and to the trauma history. I think it's important, as I conclude my review of this paper, it's important to really understand that, at least in my understanding of this paradigm, and I think what the author is really intimating, is that to be trauma-informed is not about doing more things. It's not about adding additional things on the checklist, like screening patients and making diagnoses and all this other kind of stuff. It's really about being informed about their experience to inform you, I guess, it's being redundant in my language, but about how to show up, how to be in that moment, how to be sensitive, how to be compassionate, how to be courageous and an advocate, how to role model, what's the best way to show up and engage with individuals who are in a traumatic situation. And being hospitalized is a traumatic situation. I mean, I think that's the other takeaway from here, is that there's a continuum of trauma. It's not black and white. Just like there's a continuum for health and illness, it's not one or the other. It's a continuum, and we need to respect that and not want to simplify it, because when we simplify it, we try and be discreet about it, then we exclude people that are suffering because they don't meet certain criteria. And then what do we create another label for them? Instead of just recognizing that what is traumatic to me may not be traumatic to you, but that doesn't mean that my experience is any less traumatic. So I guess that's it, you know. So check out the paper. I mean, and I also think not only check out the paper, but, you know, come and visit the Caring Essentials Facebook page and just start sharing some of your thoughts about this. Let's really start a discourse about this, particularly with regards to this concept and the language within neonatology, within pediatrics, so that we can really start looking at ways to transform how we engage with patients and families and ourselves, right? How we care for ourselves as well is equally important if we're going to really be truly trauma informed. And maybe the language that we use today, the language that I'm using right now in this moment, will morph and change and transition into a language that better captures what it is that we're trying to do, what it is that we're trying to provide, how we're trying to serve those that are struggling with their health and with all of the challenges that are connected with compromised health. Okay? All right, you guys. Well, thank you so very much. I appreciate your time. I hope you found this interesting, and I look forward to seeing you tomorrow. Same bat time, same bat channel. See you later.